First stage, latent phase. The latent first stage is characterized by painful contractions and changes to the cervix of the uterus with dilatation up to 5 centimeters. Progression might be slow and can even take days. Listen to the fetal heart rate intermittently and perform vaginal examination at intervals of 4 hours. Frequent vaginal examinations increase the risk of infection. The woman can usually be sent home if she's in the early latent phase, her membranes are intact, everything is normal, she lives with easy access to the facility, and the woman consents. Inform the woman and her companion of the signs of active labor and danger signs and welcome them back at any time. Some women need admission, care, and support in the latent phase. Recognize the woman's experience and feelings. First stage, active phase. The woman is in active labor when she has contractions that are regular with increasing intensity and the cervix is dilated at least 5 centimeters. If she does not meet these 2 criteria, she is not in active labor. The first stage, active phase, usually does not last more than 12 hours if the woman gives birth for the first time, or more than 10 hours in subsequent labors. If you diagnose active labor too early, you will increase the risk of unnecessary and potentially harmful interventions. Never try to shorten labor with oxytocin or rupturing membranes. If the woman and fetus are doing well, the cervix continues dilating, and labor is within normal limits. When the woman is in active labor, begin labor care. Explain what to expect and inform her continuously and respectfully. Start the podograph, document findings, and note the time. Good documentation helps decision-making and improves clinical outcomes. What is not written in the record is legally considered to not have been done. Every 30 minutes during the first stage, active phase, you must listen to the fetal heart rate immediately after a contraction, monitor the contractions, count the woman's pulse, assess the woman's mood and behavior. For further details and normal ranges, see practical procedures. Document your findings and provide care accordingly. Support. Giving birth can be a long, painful, and exhausting experience. The body's oxytocin works better if the woman feels safe. If the woman is scared, stressed, or does not feel respected, this can interfere with the normal birth process. Make sure that the environment around the woman is clean and private. Help her to the toilet throughout the labor period. It's important that the woman gets something to drink and eat during labor. Make sure she gets something light to eat and offer her at least 1 cup of water, tea, or juices to drink per hour. The pain often increases throughout labor until the cervix is fully dilated. Use your experience and knowledge to support and encourage the woman and talk her through the contractions. Give comfort along with her companion by offering massage, help her to shower, help with breathing techniques, help her find comfortable laboring positions. The ligaments in the pelvis get more flexible during pregnancy to support descent of the fetus, and in order to benefit fully from this, it's important that the woman is in motion and changes positions throughout labor. To support descent of the fetus, it can be very beneficial to utilize gravity by adopting an upright position during labor and birth. Second stage, cervix fully dilated. The second stage of labor is the period of time between full cervical dilatation and birth of the baby, during which the woman has an involuntary urge to push as a result of expulsive contractions and descent of the presenting part of the fetus. The duration of the second stage of labor varies. For a woman giving birth for the first time, second stage is usually completed within 3 hours. In subsequent labors, second stage is usually completed within 2 hours. You should always prepare for birth when a woman enters the second stage of labor, or even earlier if she has given birth before. Prepare 10 units of oxytocin. Alternatively, 100 micrograms of heat-stable carbetocin, or 400 to 600 micrograms of misoprostol if oxytocin or carbetocin is not available. Have the delivery tray ready and check items for newborn resuscitation, including bag and mask. Prepare a clean and dry surface under the woman and have warm towels or cloths ready for the baby. During the second stage of labor, you should monitor the fetal heart rate, contractions, and visually check for descent of the fetus every 5 minutes. The woman should be encouraged to empty her bladder every 2 hours. You should only catheterize the woman if the bladder is full and she is unable to empty it on her own. A full bladder can cause prolonged second stage of labor and interfere with uterine contractions during the third stage of labor. If second stage is still within normal limits and the fetus is still at the pelvic midpoint, it is not yet time to give birth. Encourage the woman to change position and to breathe through contractions. If second stage has bypassed normal limits, see prolonged labor. If the fetus has reached the pelvic floor, it is now time for the woman to push. Second stage, delivering the baby. Let your assistant know that birth is imminent. Support the woman to give birth in the position she chooses, preferably as upright as possible to facilitate physiologic birth. Encourage and support the woman to push according to her own urge, with legs relaxed and open to allow slow and progressive stretching of the perineum. Following are recommended birth positions: on hands and knees, half sitting, lying on her side, standing. If progress is slow due to insufficient contractions, encourage the woman to stand up or half sit. If there is no progress after 1 hour of pushing with strong contractions, the woman and fetus are at risk and may need advanced care. See prolonged labor. If labor and descent are progressing normally, perform hand hygiene and put on double gloves. Support the perineum with your hands and keep the baby's head flexed towards the woman's back. When delivering the head, instruct the woman not to push during contractions to reduce the risk of trauma to the perineum and allow the head to deliver gradually. Support the perineum until the posterior shoulder is delivered, as it can also cause damage to the perineum. Avoid the following harmful practices: fundal pressure, routine episiotomies, manipulate and stretch the perineum, manipulate the baby's head, reach in to deliver arms after the shoulder is born. This should only be performed in shoulder dystocia. Continue to gently support the birth of the head by placing one hand against the baby's head. When the head is born, allow it to rotate naturally. Do not suction routinely, even if there's meconium in the amniotic fluid. Only wipe the baby's face with a clean cloth. Check for the umbilical cord around the neck. If it's loose, slip it over the baby's head or deliver the baby through the cord. Gently pull the head downwards to deliver the anterior shoulder and then lift upwards to deliver the posterior shoulder. Immediately place the baby on the mother's abdomen and note time of birth. Congratulate the mother and her companion. For further management, proceed to active management of third stage of labor. First stage.